Good afternoon, everyone, and thank you for joining us for today's Well Aware with Michigan Medicine webinar. I'm Rebecca Cunningham, Vice President for Research at the University of Michigan and a Professor of Emergency Medicine and Public Health. I am very excited to join you all today to discuss this critical topic because for the past 25 years, I have devoted my career to exploring the root causes of potential solutions for the most important issues surrounding firearm violence. Every day across the United States, more than 120 people die from firearm injuries. Firearms are now the leading cause of death among our children and teens, and the stark reality is that this crisis is unfortunately growing more intense every year. In order to mitigate harm and reduce deaths, we need to support and catalyze firearm injury prevention research to find solutions. There is not one solution here. Decreases in the death toll will come from a layered approach. And this is where the University of Michigan comes into play. As the nation's largest public research university, U of M is uniquely positioned to address this crisis. Our researchers, some of whom you'll hear from today, have secured more federal funding to study firearm injury prevention than any other academic institution nationwide. And our Institute for Firearm Injury Prevention continues to grow. U of M will solidify its position as a global leader in generating new knowledge and advancing innovative solutions to reduce firearm injury. Together, we can advance the evidence base needed to turn the corner on this crisis. Thank you again for joining us today, and I would now like to turn things over to our panelists so they can share their innovative work in this space. Thank you.
Hello and welcome to Well Aware with Michigan Medicine. I'm Kara Gavin, a science and medical writer with the Department of Communication, and I'm delighted to be here to moderate today's discussion on firearm injury prevention. We know this is a topic of intense interest and one where the University of Michigan is playing a leading role through research, innovation, and education, and the new Institute for Firearm Injury Prevention. First, I'd like to thank Dr. Rebecca Cunningham, who's U of M's Vice President for Research and an emergency medicine physician by training, for providing that introduction to today's session. She has been a catalyst for so much of the work that you'll hear about today and more. Thank you to those of you who sent questions in advance for our experts to address later. We'll also take some live questions after the panelist presentation. So if you're watching this live on Zoom, you can submit them at any time using the Q&A button at the bottom of your screen. Now, we turn to our panelists. They are all leaders in their fields and are dedicated to making a difference on this critical issue in many ways. Through their work, they're providing much needed data on the impact of firearm injuries and deaths. They're testing and sharing techniques for identifying individuals who might be at risk of harming themselves or others with a firearm. And they're working to promote safe storage and use by firearm owners. Their work helps inform policymakers who seek to prevent firearm injuries and save lives while respecting individual rights. And now I'd like to introduce you to our outstanding panelists. Joining us today are Dr. Patrick Carter, who has provided recorded remarks. He's the co-director of the U of M Institute for Firearm Injury Prevention and co-director of the U of M Injury Prevention Center. An emergency physician by training, he's an associate professor of emergency medicine and of health behavior and health education. Then we'll hear from Dr. Cynthia Ewell Foster, who is a clinical associate professor in the Department of Psychiatry and a clinical psychologist by training. She's also working with the state of Michigan on several suicide prevention projects. Then we'll hear from Dr. Douglas Wiebe, who is co-director and principal investigator of the Injury Prevention Center and a professor of emergency medicine and epidemiologist. He is an epidemiologist, and he came to Michigan from the University of Pennsylvania this fall. And our fourth panelist is Dr. Mark Zimmerman, who is the Marshall H. Becker Collegiate Professor of Public Health and co-director of the Institute for Firearm Injury Prevention. And he leverages his psychology background as the director of the Michigan Youth Violence Prevention Center and co-director of the National Center for School Safety. So at this time, I'd like to give each of our panelists the opportunity to talk about their efforts in this critical area of research. Following their presentations, we'll begin the Q&A session. So first, I'd like to welcome Dr. Patrick Carter.
Thank you, Kara, and thank you, Dr. Cunningham, for that overview. I'm Patrick Carter. I'm one of the co-directors of the Institute for Firearm Injury Prevention, and I'll be talking today about firearm injury prevention in healthcare settings. As Dr. Cunningham mentioned at the outset, the institute that Dr. Zimmerman and I direct really focuses broadly on firearm injury prevention in a number of different areas, and focuses not just on research, but education and training, engaging with communities that are impacted by this problem, improving the data and the methodology that's done to research solutions for this problem, in ways that we can translate those solutions into both policy and programs in communities that are impacted by the problem. I'll be speaking today very specifically about some of the work we're doing in interpersonal violence prevention through healthcare settings, specifically the emergency department. And really, we think about this as how can we interrupt the trajectory of violence involvement? We know that youth who are involved in violence have a host of risk factors for that involvement, and that we can interrupt the trajectory of that involvement at multiple points during their course to prevent them from having that first violent injury. And then once they're in the emergency department with a violent injury, how do we prevent them from having the second violent injury, which we know they're at significantly increased risk for, as well as the host and range of different outcomes that we know these youth experience at higher levels: PTSD, substance use disorders, involvement in the criminal justice system. And we know that the healthcare setting is one of those really key points of interception, because this is a time when youth may be more receptive to receiving an intervention. And we know that we see them there in the emergency department for medical care, often times at really high rates before they end up there for a violent injury. And that may be the only place where we can intersect with them before their involvement in the criminal justice system. I'm going to talk a little bit about a range of different types of work that we're currently doing that are ongoing. One example of the type of work that we do is really trying to identify the population of youth that would most benefit from those programs that we develop that we find are evidence-based. An example of that type of work is the safety score. This is a score that we've developed that screens youth in the emergency department and determines their risk for future firearm violence. And through this simple 4-item screening tool, we're able to identify those youth who are at higher and more significant risk for firearm violence over the subsequent 2 years. And it can be very simply administered on an iPad in the emergency department and help identify for us who would benefit from programs. And then a lot of our work is really focused on how do we develop and test programs that we think could work through our healthcare settings. And a lot of that has stemmed from an original study called the Safer Teen Study that tested a single session, brief, therapist-delivered intervention to reduce violence involvement with a youth who might be involved in some fighting through this discussion in the emergency department. And what this original study found is that by doing this brief counseling session, they could reduce youth involvement in violence for subsequently up to a year after their emergency department visit. And it also addressed a whole host of other risk factors, such as their substance use and their mental health symptoms. And the counseling session really was comprised of both motivational interviewing, which is a particular type of therapy counseling, combined with cognitive behavioral skill development. So once youth identify that the behaviors they're involved in are not helpful to their future trajectory, we can provide them with a set of skills that they can navigate future situations to reduce violence involvement. Things like anger management and nonviolent conflict resolution and decreasing their own weapon carriage. One of the things we identified with Safer Teens is that this worked really well broadly for a population of youth that were involved in violence, but didn't work as well for those youth who were involved in more severe behaviors, such as those involving a firearm. So a lot of our more recent work is really focused on how do we build and develop a more intensive intervention that can work for those youth who are more severely engaged in these types of behaviors. And so how do we build multi-session interventions that can work not only in the emergency department, but also be delivered after the emergency department using technology-based platforms such as telehealth to talk to kids and provide these skills and provide them with access to resources in their community to help them decrease their involvement in violence. So currently we have 2 studies that are going on that really try and engage these types of more intensive interventions. One, which we call Project Interact, is really focused on addressing youth who tell us that they're carrying a firearm, provides them with a session in the emergency department, and then after the emergency department provides them with additional sessions via telehealth. In addition, we look at ways that we can supplement those therapy sessions with a therapist with technology that can deliver additional content in the same format, but in between those sessions. And in this study, we're using a smartphone app, which most kids in communities across the United States have their own smartphones at this point, to deliver both messaging and tips and access to resources that can be helpful to them and that can be delivered just in time in the moments that they need them in order to prevent these types of behaviors. We're also looking at other ways to intervene with kids once they've had a violent injury. So another example is a program that we're doing where we're delivering multiple sessions after the youth has been involved in a violent injury, much more intensive for a longer period of time, and then also trying to understand what's the optimal dose for that youth. How many sessions of therapy do they need? How much access to resources do they need? Can we adjust that dose depending on how they're doing? And so in this way, we're both looking at, does the program work, but how much of the program do they need, and how long does the program need to run in order to get the optimal impact on improving youth outcomes? Finally, the last thing I'll mention is that not only do we focus on developing these programs, but we also think about after they're developed and we know that they work, like the Safer Teens program, how do we then transition that into practice where it's being used? And so right now we're doing a study that looks at how do we work with clinicians to get them to integrate the Safer Teens program into practice, and what are the impacts of that if we do it across an entire community? In this current study, we're implementing Safer Teens in 6 clinical sites across Muskegon, Michigan, and looking at the impact in total on violence outcomes in Muskegon. I'll end by saying, I really appreciate your attention today, and I think this is a very broad, high-level overview of some of the work we're doing through emergency department settings. Hopefully, it's given you a flavor for the type of work that we do, and I'd be happy to answer other questions at a later time. And next, I'd like to turn it over to Dr. Cindy Ewell-Foster to talk about some of the work we're doing in suicide prevention.
Thanks, Dr. Carter. Hi, everyone. I'm really delighted to be with you all here today. I'm Cindy Ewell-Foster, and I'm going to be talking about firearms as a safe storage, firearm safe storage as a suicide prevention strategy. Thanks. There we go. Great. Thank you so much. You can go ahead to the next slide, please. Thanks. So, why do we think firearms are such a priority when we're thinking about suicide prevention? Well, first, suicide is a leading cause of death in the United States. It's the second leading cause of death for kids ages 10 to 14, and it's the third leading cause of death for kids ages 15 to 19 in the United States. And you can see here that firearms are used in a majority of the suicide deaths in our country. Next slide here. So if we're interested in moving the needle on suicide rates, we really need to have a prevention strategy that takes into account firearms. So we know that if someone attempts suicide with a firearm, they're very unlikely to survive that attempt. But if they pick a different method, we are just much more likely to have a second chance with folks to get them the help that they need. And there are just too many people in our nation who are ending their lives by suicide, and we didn't know that they were hurting in that way. We missed it. So we know that when kids die by suicide, they are very often using a firearm that belongs to someone in their family, or sometimes it belongs to them. So it tells us that thinking about access to firearms in people's homes is really critical. Next slide, please. So I'd like to turn to tell you about our project in Michigan's Upper Peninsula. We are seeing concerning increases in firearm-related suicide deaths in rural areas across our nation. And we've had a really wonderful, longstanding relationship with the health department in Marquette, as well as their suicide prevention coalition. And together, we really saw an opportunity to develop a prevention strategy that was specifically tailored for rural families with children And we know that rural families very frequently own a high number of firearms. So our goal with this work is to increase safe storage in all homes with kids. We really don't want to wait until kids are identified as being at risk for suicide, in our healthcare system to start these conversations about safe storage. We know that in homes where a child is injured or killed, they're much more likely to have firearms that are stored unlocked, loaded, or with their ammunition accessible. But we have lots of families in our nation that are storing firearms in an unsecured way. So we really want to develop a prevention strategy that's accessible to all homes with kids. So we also firmly believe that it's really critical to join with communities to develop health interventions that are seen as respectful, that are culturally tailored, and that have therefore a higher likelihood of being adopted in the community. So we worked really closely with the community in Marquette to develop an intervention that I'm going to tell you a little bit more about today. We were interested in learning about, who are the trusted messengers in this community? What should this message say? And what's the best way to reach people with this type of firearm safe storage message? So this slide right here highlights some of the things that we learned from our community advisory board and our focus groups. Folks really wanted to hear from messengers who had firearms expertise, not people like me sitting in a healthcare setting. They really talked a lot about pride in being a responsible firearm owner and the way that safety messages are passed down through the family. Last, people just shared a lot of really wonderful, happy memories in the woods with their loved ones, hunting and engaging in sport. And we really wanted to capture those kinds of rural community strengths in our intervention. Next slide, please. So this is Store Safely. I hope that you can see by looking at it the ways that we try to tailor for the community. This is an online prevention strategy that has a few different components. The video features some trusted messengers, a dad and a grandpa in the community, a firearm safety instructor. We use some different motivational interviewing strategies to try to increase family action around safe storage while also really reflecting their values in the cultural context and their reasons for ownership. So we tested this intervention with 45 families in the community who had kids ranging in age from infancy to high school. Families did a pre-test survey, then they engaged with the intervention, and then they did a post-test survey with us 3 weeks later. You can go ahead to the next slide, please. Thanks. So we were really pleased with how this was received. This is definitely a beginning of this work. We've got some room for improvement, but we were really pleased with the findings. So of the 43 families that stayed with us through the follow-up, we had 98% who were engaging and went all the way through the intervention. We had 86% who completed this home safety checklist, 88% having conversations in their family about safe storage, and we had almost 40% of families who said we've made a change to how we're storing our firearms. Next slide, please. So I just want to end today with elevating some of the voices of our participants and the things that they said to us that they did to make some improvements in their storage after the intervention. My favorite is the one that said it felt like it could have been my neighbor talking to me. That's how we want people to feel. I just want to sum up and say that, we believe strongly that partnering with the community to develop these kinds of health education interventions is a really powerful approach. And we're grateful to our team in Marquette for being such fabulous partners. Thank you for having me today. And I'd like to turn things over to my colleague, Dr. Weeb.
Thanks very much, Dr. Ewell Foster. I was introduced as an epidemiologist, and in epidemiology, we're interested in understanding what is causing something. If we can figure out causes of a disease or injury, we have opportunities to prevent it. Next slide, please. And, it was only 30 years ago today that the first research was done to investigate a very important question that is still asked today. The number one reason that individuals give for owning a handgun in the home is self-protection, the impression that it will keep you and your family safe. Have a look at the article on the left. This was published in the New England Journal of Medicine. This is a very sound population-based case control study. It was a study that asked the question, is having a gun in the home protective or perilous? And it was the first instance of seeing a strong study identify that, in fact, families, individuals with a gun in the home were more likely to die by gun homicide than individuals without a gun in the home. That was a landmark study published 30 years ago. And today I'll talk a little bit about the state of epidemiology that's proceeded over the last few decades. To anchor this in other areas, it was around in 1950 when the first case control studies were establishing that cigarette smoking was a risk factor and a cause for lung cancer, for example. Move forward a few years, the study on the right, I was involved in that one. And here, instead of just looking at exposures, things experienced in the home, here we looked at things experienced over the course of daily activities of young people living and growing up in an urban environment. We literally mapped the activity paths of people over 24-hour periods and found that disproportionately, young people who were exposed to certain features of the built and social environment were more likely to be shot in gun violence than other individuals. This field is looking to identify risk factors for gun homicide and gun suicide. Here we identified that features of the environment matter, and that gives us optimism about the chance to make changes to places to make communities safer. Next slide, please. Step back a little bit from in the home to where you spend time during activities to where you live in a county or in a state. In this work, we looked at firearm control laws from state to state across the lower 48. And we looked at laws including firearm dealer regulations, background checks, laws on multiple purchases, how many guns you can buy at one time. And what we coded every county in the state according to the strength of those types of laws in their state, and also the strength of laws nearby, testing the hypothesis that gun laws near you and across a state line could also influence gun injury in a given state. And indeed, that's what we found. We found strong evidence here that the strength of gun laws in a given area was a function of how strong the gun laws are in a given state and also states nearby. So again, more examples of identifying opportunities that policies and places matter for gun injury risk and giving us opportunities to make change. Next slide, please. But talk about change. Now, go quite a ways back in time. Here's what this map is. This is the landscape of Philadelphia, Pennsylvania in 1937. And this study is an example of historical place-based racial discrimination that's captured in the form of this homeowners loan corporation map of Philadelphia. What they did was they classified places across Philadelphia. Green areas are grade number 1, deemed desirable for government mortgage and lending and opportunity and economic development. Green, desirable for lending. Number 2, blue, already developed areas and stable. Third grade was yellow, evidence of decline, an influx of, quote, low-grade population. Those words were used in the legend. And then also number 4, red. These were areas deemed dilapidated with informal housing and an undesirable population. These were disproportionately areas with African-American residents. Move forward to today. The point of this study was to examine whether those classifications matter for the landscape of fire injury, and indeed, firearm violence continues to be highest in areas in Philadelphia where these areas were coded red. An example of understanding the legacy of structural racism in this country and layers and years of challenges that have contributed to the landscape of firearm violence that we're witnessing and experiencing today. So, can we change policies to make changes? Policies certainly matter. It's our challenge now of how to figure out how to change policies to make places safer. And the next slide, please. There will be no one size fits all for reducing the injury of gun suicide, gun homicide, unintentional gun deaths. And here's a paper published recently. One of the co-authors on this paper was one of the emergency medicine physicians who led that first study that I described, looking at guns in the home and homicide. Still today, those individuals are working on the issue, and here what they proposed very recently was a national office of violence prevention. And the point being, it's high time that at the office of the president, there's investment made to establish that firearm injury is a priority. And every sector, healthcare, social services, education, law enforcement, could be coordinated to much more efficiently try to work together, including with community partners, to find ways to make communities safer. Hopefully we get there someday, because right now, opportunities for funding and coordination in this area, while they're improving, are disproportionately scant relative to the burden of other types of diseases and the opportunities to bring in dollars to work on prevention and research. So I expect that we might get into some of that in the Q&A. With that, I'm very happy to turn it over to my colleague, Dr. Zimmerman.
Thank you, Dr. Weeb. You can go to the next slide. I'm basically going to talk about the last 30 years of my career and where we started looking at really violence more generally and how that culminated in this Institute for Firearm Injury Prevention. In 1984, when a few years after I got to the University of Michigan, we started a 12-year longitudinal study of Flint youth. And one of the things that we found was that adult role models and support and mentoring, identity development, specifically ethnic identity development, and involvement in extracurricular activities were associated with less violent behavior and more positive behaviors. So we translated those results into this program called Youth Empowerment Solutions. And basically, when we developed this program, it was focused on those three issues: engaging youth and adults to work together, helping kids develop a sense of identity, a positive sense of identity, especially African-American identity. We were working in Flint at the time, and it was predominantly African-American youth we were working with. And then also creating opportunities for them to engage in community improvement projects. So this after-school program was really designed for middle school youth. And we decided to help them be a part of the solution rather than the focus of the problem. So we wanted to give them opportunities to own community improvement. And so we designed this program to basically empower them, to help them develop leadership skills, and to help them learn how to work with each other and think critically about their communities and to give back to their communities. So building citizenship as well. And we compared kids who got the program and kids who were in regular after-school programs. And we found after 3 months, those in the program reported not only more positive empowerment outcomes, feeling better about themselves, feeling more able to think critically about their communities, and being more connected to positive role models, and also being more engaged in activities outside of the program itself. We found that then related to less violent behavior and less other kinds of problem behavior like drug use and delinquency, and more positive behaviors like school engagement. And we found that to be the case for 3-month outcomes as well as 1-year post outcomes. in the control group design. So what we then did is we noticed, we looked around, and some of their projects, by the way, were murals, were community gardens. And so one of the things we did is we looked at police incidents around those murals and community gardens and their projects to see what would happen. You see here a picture of some of the kids who actually, this is a mural that they built that they painted and designed. It's about 60 feet long and about 12 feet high. And there's an interesting story behind it, which I won't get into it right now. But one of the things we found around this mural and some of the other gardens is that crime actually was reduced before, compared to before and after their projects were complete. And that effect dissipated about 300 yards. At about 50, 100, even 150 yards, we saw around those areas, we saw less time, less outcomes. So that led to the next project that we sort of developed, which is this idea of a busy streets theory, which is the next slide, and where we started looking at vacant lot reuse. We work in Flint, where there is one of the highest vacancy rates in the country. And we studied community engagement in the idea of repurposing empty lots. And in control group designs, again, we found that when communities engaged in making the place a better place, a nicer looking place, mowing the lawn, planting a garden, cleaning it up, that there was less crime and less violent crime in those areas versus street segments that had those sorts of that didn't have a vacant lot reuse. And importantly, we came up with this idea of busy streets theory as a counterpart to broken windows theory, which is the idea that if one broken window is present, it might suggest that fewer people are paying attention. And so that leads to the next broken window and leads to the slippery slope of the declining neighborhood. And so we thought, if we build it, do they come? And that's the idea of busy streets, where we get more people engaged in that process. And then lastly, the next slide, this culminated in what we're also working on is the National Center for School Safety, which is really a culmination of youth development, community and school interaction, and the whole idea of the importance of creating positive environments for kids to grow up in. And the National Center, we do technical assistance, we develop training materials, all evidence-based research, and we also engage experts from around the country to help us with the materials we develop. And all of the sites, all of the websites of all the different projects I just described were included on each of the slides. So I want to just thank you for the opportunity to share some of this with you, and I'll send it back to Kara.
Thanks so much, everyone, all of our panelists. You are so giving of your time, and you have very demanding schedules. So thank you so much for sharing your thoughts and your presentations. So now I'm going to invite all of our speakers to come on screen, and I'm going to invite our audience members to use the Q&A function, if you're watching live on Zoom, to submit questions for consideration. And also for our audience members, please note that our presenters can't give personal recommendations at this time, but they can give general advice. And since this is an event that's focused on research about firearm injury prevention, they also won't be making specific policy or legal or law enforcement recommendations. So now we'll start the Q&A portion of the webinar, and we're going to start with some of the previously submitted questions and then add live questions as time permits. So the first one's actually for Dr. Zimmerman. Do we have everyone on screen? Great. So Dr. Zimmerman, can you give us a quick breakdown of the types of incidents that lead to firearm deaths in the United States each year? We've had several questions come in about homicides, suicides, mass shootings, other types of incidents. So how does that break down?
Well, it's a really interesting question. And I think this is, I often start talks with talking about what do people immediately think about? Often it's community violence or mass shootings. About 60% of all homicides, I'm sorry, of all firearm deaths are actually suicides. And most of them are white men in rural areas, and many of them are veterans. About 40%, a little under 40% is the community violence that I think people think about, and that's the crime that I actually study a little bit more of. And only 1% are mass shootings. And what's another interesting little fact here is only 10% of that 1% are actually school shootings. Most mass shootings occur outside of schools. That's to say that schools are still a relatively safe place. However, what happens, and I think this is kind of, all my colleagues will agree, that the precursors to firearm violence are often similar to just violence in general. So a safe school is one where there's no bullying. It's not just necessarily one where there's no shooting. So I think we have to think about that. And the other issue is there isn't a single solution. I get very frustrated when I talk about this work and people always, say, oh, all we need to do is, it's not all we need to do, because it's really different. The kinds of violence that mortality that happens around firearms in rural areas, in urban areas, and suburban areas, it really differs by population. So it's a really great question. I think it speaks to the fact that it really will take many different strategies to address the problem.
Thank you so much. And both Dr. Ewell Foster and Dr. Zimmerman, you've both told us about your own projects that are studying community-based approaches to this problem. But maybe we'll start with Dr. Ewell Foster. Are there others that you're hearing about, other projects going on at U of M or around the country that are having success in making inroads on this issue?
Yeah, thanks, Kara. I absolutely agree that this is a problem that is going to require a multidisciplinary, multi-sector, sort of all hands on deck solution. And there is great work happening everywhere, around this issue. I want to highlight a different project that our team is actually working on here at the University of Michigan in partnership with the Michigan Department of Health and Human Services and funded by the CDC. We're actually leading a statewide dissemination of counseling on access to lethal means, which is a free, publicly available training to help us get comfortable having conversations about people's access to firearms. It's a suicide prevention strategy that many of us that work in healthcare are really familiar with. Having a conversation with somebody that, hey, we're worried about your risk for suicide. Do you have a firearm in your home? Let's talk about how that can be stored more securely while you're struggling, right? And then we can talk about it again in a couple of weeks. But this, as folks know, it can be a sensitive topic and it can be challenging if folks don't feel like they've had training to have those kinds of conversations. So this is a great free training that's available, and we're just working to get it out across our state and do some, science around it also. It was designed actually for behavioral health clinicians, but we really feel like, again, thinking about this multidisciplinary partnership, that these are conversations that a lot of people could be having, clergy in our state, law enforcement, folks in human resources, right? Like, let's think broadly about who could, have awareness and have these conversations. The other, I think, really neat project that's happening nationally, folks may have heard of, is a partnership with the firearm owning community, which I know we really embrace this idea here at U of M, but it's called the Gun Shop Project. And it's a collaboration between suicide prevention folks and folks who own gun shops. It's about getting them training. How do you know if a customer is coming in and feels like they're at risk for suicide, they're wanting to purchase, because they're at risk for suicide? What should you do if your gut tells you that you're worried about someone? And how can we use those structures, gun shops and shooting ranges and that type of thing, to just get some more, health information out to folks? So that's a, collaboration that's happening all over the country and, really cutting edge.
Great, thank you so much. Our next question that was submitted has to do with the role of researchers in evaluating what happens after a firearm law or regulation changes. So can you do this kind of study in real time to show the effects and then share that information with the public? And Dr. Weeb, do you want to take this one on?
Happy to. Thank you. It's a great question. Certainly, we're in a position to evaluate policy that is introduced or changed to test whether that has had an impact on firearm injury or something to do with access to firearms and so on. Can we do it in real time? Um, Pretty close, but current day, as we speak, there will be a lag. Um, for statistical purposes, if we're interested in testing whether there's a change in a rate of an injury over time, we need a little bit of time to pass to see whether or not that's changed. But it may not be long. Maybe you need months to pass before we can evaluate a potential impact. Now, how do we get data for that, though? Contributing to the lag, data sources in this country are continuing to be built and honed, and there are efforts to make even faster access to sources of data so that we can really keep our finger efficiently on the pulse to be able to test closer to real time whether policy changes lead to intended outcomes.
Great. And building on this data question, are there other kinds of data that firearms researchers need to do their work and that you're having trouble getting at, or what could make that situation better? I don't know, Dr. Zimmerman, would you like to start on this one?
Yeah, I mean, it is a relatively frustrating. I mean, as Dr. Wee pointed out, the research on this area has lagged over the last 30 years because of politics, basically. I won't go into all the details about that, but that veil is being lifted, and we're starting to get involved in identifying data sources. It could include 911 data, could include hospital data. We don't really have a good handle in the United States on injury. We have pretty good information on death related to firearms, but not injury. And I've seen estimates 60 to 100,000 people each year are injured. That's a pretty wide band to get it. So having some kind of surveillance system, we've been actually trying to work with our state to kind of think about ways that we can get a surveillance system in place that would allow us to do that. Emergency departments would be another source of data. 911, police incident data is when the incident occurs, but we did not as much about the injury. So yeah, data is a very important issue for those of us who are in an academic setting, because that's how we develop evidence base. And we're all data nerds. I'm sorry for calling us names, but we all like data. Data is what informs and allows us to evaluate the kinds of things that we were talking about before. So yeah, we are lacking, but we're building.
Great. And I just want to clarify, since data people speak a different language sometimes, surveillance, when you describe it, is ways of getting real-time information from, say, a hospital emergency room network, to then be able to be accessible to researchers. So it's not surveillance through cameras or anything like that. Just want to clarify that term. Great. We have another viewer who actually had noted in our invitation, we talked about how the reduction in deaths and injuries from car crashes, from vehicle crashes, has declined over the last 50 years because of injury prevention research. And this person noted that that didn't happen overnight, and that there was resistance to doing some of the things that researchers were suggesting might help prevent car crashes or big truck crashes and things like that. So are we seeing that with firearms research, and what's the path forward? And Dr. Weeb, maybe you could consider this one.
So good, great question, and best example. In public health, we say that the massive reductions achieved in motor vehicle crash, death, and injury are one of the biggest public health success stories of the 20th century. Think back to 1950, the number of injuries and fatalities happening each year was just massive. And as a field, how do you take that on? Because it seems intractable. Well, looking back, we see that it was quite deliberate. That large problem was broken into component parts. what can we focus on in the field of injury prevention to try to start to move the needle and achieve prevention? We can focus on individuals who are at risk of being injured, which Dr. Ewell Foster is doing on education of firearms in the home. We can also focus on the vector, that was the vehicle for motor vehicle crash, airbags, absolutely helpful in protection, and they weren't always there. We have chances to make firearms also safer, but there are so many firearms in existence. We need to live in the context where we live. We can also change the physical environment, as you're hearing Dr. Zimmerman talk about, and we can change the social environment, change policies. And we can be even more concrete. We can target interventions to ideally be primary prevention. Stop something bad from happening before it even does in the first place. That's ideal. Secondary prevention, if a gunshot injury happens, get them to definitive care as quickly as we can, work on the trauma delivery system and healthcare systems. And then also long-term care, it's tertiary prevention. For those who survive, work on improving long-term outcomes. So, there's a formula to follow. I'm dictating what's called the Haddon's Matrix. Dr. Bill Haddon worked in motor vehicle crash prevention in the 50s. And by breaking it into its parts, that's how we actually think in this field. So we've got to come up with these different ways to populate different parts of this grid, and they can all come together to lead to prevention over time.
I would
Fantastic.
like to add
Oh,
something
please.
to that,
Yeah.
if you don't mind. One is that, so you just got a quick lecture from a professor and you didn't even know it. So take your medicine and you didn't even know. But seriously, the other thing I think that's really important about the and that I like to point out about the car crash analogy is that we were able to achieve that decline over many years with significant dollar investment. There's something like 26 some odd transportation research institutes in the United States, one of which is here at the University of Michigan. But we were able to do that without taking anybody's car away. In fact, people are driving, there's more cars, they're driving faster, and they're driving further than ever before. And I'm convinced that we can do the same thing with firearms without taking people's firearms away, without limiting people's rights to, their firearms if they, so desire. There are ways to make changes that are safe and protective and respecting rights.
Thank you, Dr. Zimmerman. Dr. Ewell Foster, we've had several questions about the role of addressing mental health needs broadly in this country as part of the effort to reduce suicides and mass shootings and more. Could you comment on what you feel is needed and whether you feel things are heading in the right direction when it comes to mental health?
Yeah, thanks, Kara. And I welcome my colleagues to jump in also. I should say I'm a child clinical psychologist by training, so I think a lot about kids and families. And one positive that I think is happening in our national conversation, I think spurred by COVID, I think spurred by some of the concern about firearm violence, is people are starting to really think about mental health. They're starting to talk about it. And I think anytime we're having a national conversation where people are saying that they feel like this is important, that's a good thing. Often from those national conversations, we see investment and attention. And so I think that is a good thing. I do, want to be realistic and say, I think a lot of folks are worried about our children's mental health crisis right now. We've had the American Academy of Pediatrics, American Academy of Child and Adolescent Psychiatry, our Children's Hospital Association say we are having a children's mental health crisis right now. Those of us who've been in the field for a long time know that things weren't actually so hot before COVID, right? We had about 1 in 7 kids in this country who have a diagnosable mental health condition. Again, there's kids who maybe don't meet criteria who would really benefit from help, in addition to that 1 in 7, and only about, 50% of the kids who were meeting criteria were getting specialized mental health care. So the point is, there's an awful lot of kids in this country who are struggling, and we haven't been able to get them the help that they need. And so I'm so glad we're thinking about this and we're talking about it. In terms of things moving in the right direction, one of the things that I feel positive about is I think we're really starting to realize that access to mental health care is not distributed equitably in our society. And we have a lot of kids in different subgroups and families who are not as able to access care, right? So maybe that's families of color, families below the poverty line, families in rural areas where there's nobody to go to if you try to, because there's no psychiatrist there, there's no psychologist there. So, I think one of the great things that's come out of COVID is telehealth, right? And our ability to try to meet people where they are with what their needs are. And lots of great science happening, some of it at U of M, really talking about the benefits of telehealth in terms of access to care. And I also think we're just working hard to try to meet people where they are. So certainly in Michigan, working on moving mental health care in all the places that kids are, schools and integrated primary care, working with pediatricians, trying to get those evidence-based practices out so that it's not so hard for people to access them. But, I welcome my colleagues to jump in too.
I would just say then that's exactly what we're trying to do in the National Center for School Safety. It was funded as really an outcome of the families working from the Sandy Hook Promise Foundation and the shooting that occurred 10 years ago, almost to the day, December 14th. And one of the things we're doing is that they do is focus on school climate, focus on creating schools being a nurturing and supportive place, focusing on knowing the signs and intervening early, having mental health first aid in schools. This is where children are and where they're at. It's also recognizing that not everything happens in the school building, and then thinking about goes outside, and kids bring to school what happens at home or happens in their community and vice versa. So it's really all of those things, but mental health is clearly an issue down the line. We also have work on trauma-informed care, understanding when they're coming from communities and from experiences of violence in their neighborhood, what that means when they come into a classroom or into a school. So I think it plays itself out in all those ways.
Thank you so much. And we're running low on time. So I wanted to ask each of our panelists to maybe actually tackle a question that came in live, which is, what are you most hopeful about for the future of firearm injury prevention? And if you want to talk about some research initiatives that are just getting underway or that you're seeking funding for, please go ahead. So Dr. Wiebe, let's let you go first.
Hopeful. We have never seen before the investment in firearm injury prevention, research, and efforts to do truly, genuinely community engaged work, to work on prevention, evaluate the processes and the methods we try, learn what works and what doesn't, and use those elsewhere. There's investment federally and also at the state level. I think a challenge is to quickly stand up efforts that are robust and can be evaluated in real time. But we had always hoped that a day like this would come. So it's an exciting time in this field. Thanks.
Great. Dr. Ewell Foster?
I'll just say I'm excited because I just got back from our nation's first research conference around firearm injury prevention. Lots of us were there. It was just, that's so hopeful. There was a huge room full of people with all different backgrounds, violence prevention, suicide prevention. I mean, really thinking about this from so many different angles. And, I thought the room also looked like our country, right? There was just so much representation there of different groups that are touched by firearm violence. And so, that gave me a lot of hope. And thanks to U of M for being a co-sponsor of that event.
Yeah, I think the Institute for Firearm Injury Prevention is a hopeful sign that we've gotten to the game in a big way. We're probably arguably leading the nation at this point in terms of this. Not that we're the only game in town, but we certainly are a campus-wide effort. The other thing from that conference that you just heard about, we're hearing more and more young people getting into the business, and that's what it's going to take. So I'm very hopeful that people are seeing this as a potential career opportunity. I recently had a conversation with an African-American woman who is getting interested in this area. And she said, 20 years ago, 10 years ago, if I had done this, it would have been the end of my career. Now she's seeing this as an opportunity to really do something about, inequities that exist in our country. And it's hopeful. I'm very, very hopeful for the future.
Fantastic. So I'm going to end with asking each of you to, in 10 or 15 seconds or so, say the one thing that you hope folks watching this, whether it's live or recorded, can do in their own homes, their own communities, or in their practices if they're clinicians to reduce risk of firearm injury and death. Dr. Ewell Foster, why don't you go first?
I would say store your firearms safely.
That wasn't even 10 seconds, Dr. Weed.
Talk about it. It's important for us to be talking about and to get on the same page and talk about differences, because we can come to agreement on how to be safe and live in a country where firearms are plentiful.
I don't know how to beat either one of those two things. I would say think ecologically, meaning that it's going to take a village to address this issue, and we need to be open-minded about that. And to be able, I think it's vital that we open up the conversation and realize that we can make these changes without necessarily interfering with people's rights.
Fantastic. Thank you all. Now I'd like to ask my colleague Joe Pifferetti, who is the Senior Director at the Michigan Medicine Office of Development, to conclude today's presentation.
Thanks, Cara. Apologies for that. I'd like to finish with just a few quick wrap-up comments. Firstly, thanks to all of you for joining us today on this webinar. The attendance and thoughtful questions that were submitted really do speak volumes to the importance and interest in this topic. I'd also like to thank all of our panelists for joining us today and for sharing their expertise in general. The session has been eye-opening, thought-provoking, and given us all an insight into the complicated issues of firearm safety and how we can prevent firearm-related injuries. I'd like to extend our gratitude to the community of donors who support our efforts in so many ways. And thank you in advance to those who plan to support the Institute of Firearm Injury Prevention Fund that we linked to in the chat. Your support will help us conduct research, prevent tragedies through common sense precautions, and reduce deaths related to firearms. Your support will also help us to partner with advocacy groups to explore these issues on a broader perspective and help those in communities at risk for firearm-related violence. As a reminder, we'll be sending out a recording, including the resources discussed today, in an email to everyone who registered, in case you want to watch it again, share it with family and friends, which we would very much encourage. And finally, please visit the Well Aware website from time to time to stay informed on our quarterly webinars. We'll also send information to you soon regarding future events. Until then, please stay healthy and safe. Thank you so much.